on the HCA website on the SURSAC page. Hopefully everybody has a link to that. All meeting recording and meeting materials are open to public disclosure requests, so please remember not to share any confidential information. Next slide, please. Just a couple quick reminders about language and terminology. You know, we've been sharing these over the past several months. Just be mindful about the language that you're using. Use person first language. If somebody does use a term that we would typically not use within this setting, use it as an opportunity to educate and inform and provide an alternative term to use. And then there's a resource here about words matter, terms to use and avoid when talking about substance use disorder and addiction. Next slide, please. Quick guidelines for public feedback. We will usually allocate 5 minutes at the beginning of every meeting, as well as 5 minutes at the end of every meeting for public public comments. Each person will have no more than 3 minutes to provide feedback. And then we also try to make time around the agenda item. So if we have an agenda item and there's a presentation or a conversation, after we have that initial presentation or update provided, then the SURSAC committee members will have an opportunity to ask questions, provide additional comments or information. And then after that, we'll also open it up to the general public and other people that are attending the meeting to provide commentary as well or ask questions. Any feedback that's not provided during the meeting can also be submitted via email at any time to hcaesb5476@hca.wa.gov. Next slide. That's the last slide. So we'll pull up the agenda real quick and go through that. Just as a reminder, in case you're new to this meeting, my name is Tony Walton. I'm a section manager within the Division of Behavioral Health and Recovery. I use he, him pronouns, and I'm the chair for this committee. I'm gladly doing it every month and working in between the monthly meetings to help support this work and help support the content and conversations that we have. And just really appreciate everyone that joins the first or Monday, or in this case, the second Monday of the month, to talk about these critical issues as they relate to substance use disorder, supporting individuals who use drugs. So apologies, we'll have to manually admit people, so you'll continue to hear the little beep when somebody joins, so apologies for that. Real quick review of the agenda. We have some time for committee member announcements. Hopefully there's some new updates from the committee about stuff that they're working on, what they're experiencing within their community or their subject matter expertise. We'll have time for some public comments at the beginning of the meeting. And then we have two kind of big conversations, one around the Involuntary Treatment Act and secure withdrawal management and stabilization. And we have guests from other sections within the Division of Behavioral Health and Recovery at the Healthcare Authority, Luke Wagner and Zephyr Forrest. And then we also have a guest from Washington State University, Dr. Susan Collins, joining us. After that, we will talk about our RMP quarterly report. So looking at, oh my gosh, I forget which quarter of data it is, but Brianna will remind us, and Brianna will present on those data towards the end of the meeting, and then we'll close out the meeting. I kind of jumped over HCA announcements. My apologies for that. Let's see here. And again, opening this up to other colleagues at the Healthcare Authority or colleagues at Department of Health to also share any updates that you might have. I'll get us started, but also feel free for others to jump in. Definitely want to make sure there's opportunity for others to share the good work that's happening. Our new director at the Healthcare Authority started back in the middle of August 16th, Ryan Moran, joining us from the great state of Maryland. And we have slated for the next meeting in October, time for Ryan to come and introduce himself to the committee and see the committee in action and kind of hear about the work that we're doing. So really looking forward to our October meeting and having Ryan join us. maybe some updates that people can provide in the chat is some of the events and the outcomes from the events around International Overdose Awareness Day. As a reminder, that was at the end of August 31st. I know there was a lot of events the couple days prior on the day of, as well as Tacoma Pierce County Health Department had their event last Thursday. And that's it segues into Recovery Month for the month of September. September is Recovery Month, and a great month to acknowledge all of those who have at some point had a substance use disorder or problems with substance use, and have found recovery, are in sustained recovery, or short-term recovery. And there's going to be a lot of events throughout the month, including a Recovery Day at T-Mobile Park. For those of you that don't know me as well, I'm a huge baseball fan, and so love when Recovery Day happens with the Mariners, and it's always great to see how many people come out to join that event. And so just a lot of work happening. And I completely skipped over roll call, but that's all right. And then finally, I don't know if Chloe Wilkins is here, but we have craft trainings scheduled in November. We've talked a lot about craft and that model of support in this committee over the past couple of years. And I don't see it in the chat, but we can get that information out. I think we sent out a Gov delivery with information about the craft trainings. They fill up fast, so just wanted to make sure everybody knew about those. And I'm going to pause there. Luckily, we have plenty of time, and see if anybody else has any announcements. And then I'm going to backtrack and actually do roll call and see who from the committee is here with us today. So opening up, anybody else have any from like the Healthcare Authority, Department of Health, any other announcements for the committee? Okay, apologies for having to backtrack. We're going to do some introductions in the room just so everybody knows who's in the room supporting this work, and here in person at Cherry Street Plaza in Olympia. And then we'll do roll call with the committee members as well. And so apologies for skipping over that. So we have others in the room here today. I'll start here and we can kind of go around.
Hey, good morning. Sarah Melfi-Klein with Healthcare Authority, Division of Behavioral Health and Recovery. I use she, her pronouns, and I am one of 2 supervisors on Tony's team, and I oversee the criminal legal systems and Blake Projects unit. So a lot of the work coming out of the State versus Blake Supreme Court decision, including SURSAC and the SURS plan. And I'll hand it over to Melissa.
Hi, everyone. Melissa Temke. I use she, her pronouns. I'm HCA's Behavioral Health Communication Manager. So myself and my team support any and all communications that go through HCA's Division of Behavioral Health and Recovery. I'm just here to listen and learn. Morning.
Hey everyone, Tim Candela. I am from the Washington State Department of Health, housed inside the Office of Infectious Disease. I am the Drug User Health Advisor. I support various activities within the Healthcare Authority, while also supporting the work of the Office of Infectious Disease, which are the Drug User Health Team is specifically focused on naloxone distribution and supporting harm reduction programs such as syringe service programs, which DOH has been supporting since the early 90s in response to the HIV/AIDS crisis. Good morning, everybody.
I'm off camera, but my name is Rachel Downs. I use she, her pronouns, and I am with Healthcare Authority in the Division of Behavioral Health Recovery, and I'm the admin assistant helping with the adult substance use disorder treatment team, specifically helping with Sarah Melfi-Klein's unit.
Awesome. Thanks so much, everyone. And so I'm going to do a quick roll call, and then we'll move forward with the agenda. So going through the committee member list on the agenda, starting with Senator Manka Dhingra. Senator John Braun. Representative Lauren Davis.
Good morning.
Good morning. Representative Brian Burnett. Oh, awesome. All right, thanks. Good to see you. Caleb Banta Green.
Good morning, very present.
Hey, good morning. Don Julian Saucier.
Good morning.
Hey, good morning. Sean Meyer. I haven't seen Sean in a couple months. Alexi Orr. Amber Cope.
I'm here.
Yes. Hey, Amber. Brandy Flood. Brandy, are you here? Okay. Stormy Howell. Chad Enright.
Good morning. I'm here.
Morning, Chad. John Hayden. Oh, looks like Alexi's joining. Awesome. Nikki Lewis.
Hi, good morning.
Good morning, Nikki. Sherry Candelario. James Tillett.
Good morning, present.
Morning, James. Christine Lynch.
Good morning.
Good morning. Sarah Gillard.
Good morning.
Good morning. Danelle Tanksley. Malika Lamont.
Present.
Good morning. Addie Adwell.
Good morning.
Good morning. Kevin Ballard. Hunter McKim. Representative Mary Levitt. And then Representative Deb Manjarez.
Present.
Hi, good morning. Okay, awesome. So we have about 13 present and accounted for, and so thank you so much. One other update before we move forward in the agenda. Just wanted to share this with everyone because it's kind of a big piece of information. It's a big piece of our community behavioral health system. Back on August 29th, we had a great team at Division of Behavioral Health and Recovery submit our block grant application. So the Substance Use Prevention, Treatment, Recovery Services, and our Mental Health block grant applications to SAMHSA, the Substance Abuse Mental Health Services Administration. So such a large amount of funding, the funding that comes through those block grants is so critical to supporting the gaps in our system that aren't filled by Medicaid and for uninsured, underinsured individuals in our crisis system. And so just wanted to let everyone know that that was submitted on behalf of the state of Washington. Last year, we received around $41 million in an award based on the proposed House and Senate budgets for federal fiscal year 26 that's making their way through the legislature. It looks like we're anticipating around that same amount when awarded for this coming year. And so just such important work that's happening that I wanted to make sure that the committee was aware of. And so sorry for getting that as part of the initial updates. Okay. Hey, Blake, are you there?
I am here, Tony.
Blake, how you doing today?
I'm doing well, thank you. Hi,
Good.
folks. Blake Ellison with the Healthcare Authority. We are at the point in the agenda where we are looking for committee member announcements. So if you would like to make an announcement about any goings on in your area, your world, please raise your hand virtually and we'll get to your announcement. So again, calling for committee member announcements. Anything going on that you would like to folks to know? Malika.
I know we were supposed to be providing like updates around different activities that we may have engaged in. And
Please.
so I just wanted to let folks know that this year Vocal Washington was able to go to International Overdose Awareness Day events throughout Washington State. And we brought our mural of remembrance with us to many of those places around the state. And it was very well received. And our International Overdose Awareness Day event in downtown Seattle was really beautiful. It was a place for healing and support for both practitioners of services for folks as well as the people that we serve. And so just wanted to give that update. Thank you.
Thank you, Malika. Any other updates? Caleb.
Good morning. Just want to let folks know after many years of hard work, the Opioid Recovery Care Access Center opened in downtown Seattle last Monday at Downtown Emergency Services Center, Morrison Hotel. And there's just an amazing body of work that is going to provide the ability for Seattle Fire to divert people from the emergency department, either post-overdose or at high risk for overdose, and also allow for folks to walk in. And word was that on the first couple of days, it was very, very popular for walk-ins, with many people getting started on buprenorphine same day. So we're super excited about that.
Awesome. Thank you, Caleb. Any other announcements? Okay, don't see any other hands. So we'll move on to public comments. Now it's time for members of the public to make any comments you would like before we start in the bulk of the agenda. So if you are a member of the public and would like to make a comment, please go ahead and raise your hand virtually. Again, time for public comments. If you would like to make a comment, please go ahead and raise your hand virtually. Right. All right. So it looks like we don't have any public comment today. We will have another, well, actually, we'll have another opportunity at the end of the meeting. So, Tony, you want to introduce the next topic on the agenda?
Yeah, absolutely. Thanks so much, Malika and Caleb, for those updates about the Orca Center, as well as the Wall of Remembrance and International Overdose Awareness Day. Our next agenda item, Rachel, do you want to pull up the agenda real quick? Just so I remember what we called it. This is kind of a continuation of the conversation that we briefly had at the conclusion of our August meeting. Representative Manjarez asked a question regarding civil commitment, voluntary treatment. What are we doing to help get people into treatment that are suffering in the community? And it's we had a really quick, like 5-minute lively conversation, and I think people provided good resources, provided good context. But we wanted to, and at the end of that, I said, we'll set aside time on our September agenda to kind of invite others that work more closely within the involuntary treatment space, specifically around substance use disorder and voluntary treatment, to this meeting to provide additional information, education, context. And then we can also have additional time for questions and comments and hopefully a dialogue about, as far as our entire continuum of services for individuals who use drugs or might have a substance use disorder, where does civil commitment fall in that continuum? And what does that mean in terms of SURSAC and the previous 3 years of work that we've been doing here? And so we put together a little presentation as a team effort, a cross-team effort with the involuntary treatment team, as well as with Sarah and others from the adult substance use disorder section within DBHR. And so we're a little ahead of schedule, but I think that's okay because we allotted 45 minutes It's a short presentation, but hopefully we'll have plenty of time for questions, comments, additional input from the committee members and even the public as to their experiences within this. So just really looking forward to the conversation today. And we put together, like I said, a short presentation to just kind of like help scope the conversation. And so happy to share that today. And yeah, that's the background for that agenda item. And I think we almost have the PowerPoint presentation pulled up. And what we'll plan on doing is after this meeting, when we send out the minutes, we'll also send out the PowerPoint presentation in like a PDF format. And then those will always be uploaded to the committee website as well. Okay, and so I'll pass it off to Sarah to get us started.
Thanks. Rachel, go ahead to the next slide, please. Thank you. So I just want to start with setting some foundation for involuntary treatment within the context of this committee's work and the Substance Use Recovery Services Plan, since we do have a number of new members and folks who haven't been along for the whole ride. So this committee was tasked with recommending a plan to implement measures to assist persons with substance use disorder in accessing outreach, treatment, and recovery support services that are low barrier, person-centered, and informed by people with lived experience, and are culturally and linguistically appropriate. And that is the RCW language that put this committee. The enacting legislation for this committee also compels the committee to prioritize service delivery that establishes low barriers to entry and uses non-coercive methods of engaging and retaining people in treatment and recovery services. It's through these guiding principles and after extensive presentations and written material that the committee reviewed by professional and lived experts in substance use disorder treatment that the committee ultimately put forth 17 recommendations for consideration by the legislature. And I will drop that link in the chat here just as soon as I can. You can see in these recommendations a focus on low barrier treatment options in community and on social determinants of health like access to recovery housing and education and employment support, as well as a prioritization of non-punitive responses to people struggling with substance use wherever possible. There's a whole continuum of substance use services, which I'll kind of hand it off to Tony after this to speak a little more to. And involuntary treatment is at one extreme end of that spectrum. And while it may be effective for some, this committee had to look at treatment options that demonstrated efficacy at a broader population level, since they were tasked with population recommendations that span the entire state of Washington. Additionally, this committee considered the unique challenges presented by the fentanyl crisis, causing an unprecedented rate of overdoses. And what's unique and important about that in the context of involuntary treatment, I'll speak to here as well. But because the fentanyl wave has changed the public health and treatment landscape, this has really driven a need for policy change that address the unpredictability and toxicity of the illicit drug supply and necessitated treatment options that are protective against overdose. We know that stopping taking drugs and picking them back up after a period of abstinence can increase risk of overdose, which is why treatment options that take place in a locked and controlled environment can pose a risk to individuals when returned to their previous environment where they were using. So this committee certainly did consider involuntary treatment as part of the entire substance use treatment continuum and recognize that it may be effective for some individuals under some circumstances. However, faced with the reality of the current fentanyl epidemic and understanding that forced treatment does not have demonstrated efficacy at a broader population level and can increase risk of death, this committee did not put forth recommendations to expand involuntary treatment options resulting from substance use disorder. And Tony will speak a little bit more to that substance use continuum. Skip the slide.
Yeah, if you can go back one slide, Rachel. Thank you. Okay, thanks so much, Sarah. And so just a quick comment about this slide. It's not intended to be linear in nature, just identifying the various points around the continuum, as well as not comprehensive. And so, I think there are a lot of different ways that an individual can engage with and be supported by the entire continuum of services for individuals who use drugs or might have a substance use disorder. So that's just one point I wanted to make. The second, and I kind of just made it, it's also important to acknowledge that the majority of individuals who use controlled substances do not meet the diagnostic criteria for having a substance use disorder. I think that's important as we talk about this and kind of go through this continuum, because there are programs and there are efforts to help support individuals who use drugs. And it's just important to just note that there's not always that clear distinction that just because somebody's using illicit controlled substances, that they have a substance use disorder and require these additional levels of care or escalated levels of care. And so some of the ones that we just kind of laid out are, starting with prevention, upstream services, ways to help engage with somebody maybe at the initial drug use at a younger age, and how those preventative services can help them not, go forward with continued use that might eventually become a substance use disorder, and just such a critical component and a critical point across our community behavioral health system. Next, we outlined were supportive services. I mean, I think with all of these different intervention points, the idea of compassionate support and supporting somebody where they're at, through whether it's housing, healthcare, job assistance, food assistance, is just so critical to ensure that somebody has those sort of wraparound services that will help address some of the underlying issues that are reinforcing the substance use that might lead to a substance use disorder. Then we have voluntary treatment. I think this is where we really hope to capture a lot of individuals who are in need of services. And this is where we see our kind of ASAM levels of care and our core services like outpatient treatment, withdrawal management, residential services. This is all for individuals who are voluntarily accessing services and who are not necessarily being forced into treatment or coerced into treatment, but instead walk-in crisis centers. And then within those, the inclusion of medications for opioid use disorder. So ensuring that along those kind of core services and those continuum of care in our community behavioral health system, that medications for opioid use disorder, low barrier access to those medications and low barrier access to other services are embedded along those different intercept points or those different pathways. Also wanted to call out our opioid treatment programs. Our state opioid treatment authority has done such an amazing job expanding OTPs across the state over the past 6-7 years. I forget the exact number, and we can always invite Jessica Bloss and her team to come and do a presentation around opioid treatment programs. That was one of the SURSAC recommendations, to expand mobile OTPs and mobile access to those services. And there's just been so much growth in this state, and we know that methadone, especially in light of fentanyl, is just such a crucial medication to help individuals address that fentanyl use and help get them in kind of sustained off of the dependence on the fentanyl use. In terms of, and it's under voluntary treatment, but I would almost say it's for all of the levels, really focusing on low barrier, on demand, individually driven services, ensuring that we don't create unnecessary administrative, logistical barriers for somebody to access services when they are wanting to access them voluntarily, and ensure that any of the services being provided are individually driven, that they're taking into account the voice of the individual accessing those services, that we're listening to them, shared decision making. So much is happening in this space that it's really difficult to put it all on one slide, and so that's why it might seem a little disjointed. But just wanted to call out some of the really important critical components that need to be present when engaging with the population. And then one thing that we kind of missed, around that voluntary treatment, and I'm gonna, kind of use a term that I've heard in this space in the past, but how do we engage with a non-treatment seeking individual? We know that there's individuals out there, somebody who's struggling with substance use, who might have a substance use disorder, and they're not necessarily actively seeking treatment because they might have had a negative experience in the past. They might have, gone to a treatment center or had to go to the emergency department or were hospitalized. And their faith and their trust in the ability for the system to support them where they're at and do it in a compassionate way might have been fragmented. Like there might be a lack of trust in the system's ability to support them. And so how do we engage with somebody that's not actively seeking treatment or might have had a history of failed experience in the treatment system in the past? I think that's where like really innovative work that's coming with our health engagement hubs that this committee recommended as well is, you know, looking to create that kind of ancillary model of care where we can help support somebody in a way where it is done in a non-traditional setting. And then we move into recovery support services. So all those services that sustain and support initial and long-term recovery. Obviously, recovery support services are critical and necessary along the whole continuum. Like I think there's, you know, when we talk about things like access to food, housing, peer services, there is transportation. There is a need for that, whether somebody is within voluntary treatment or if they're in compulsory treatment or involuntary treatment. Just in ensuring that there is access to those supportive and recovery support services. Next, I'm going to kind of start moving towards the end of the continuum where we start to see things like compulsory treatment, you know, court-ordered treatment, deferred prosecution based on DUIs and other charges, therapeutic courts, probation. You know, I would even almost lump like some of our jail-based services within that because there's some preceding event or some act that is compelling that individual to get services, you know, whether it is through a plea offer because they have a criminal charge that's associated with their substance use or their substance use disorder, and they're given the choice, right? Like they're given a choice of either serving 12 months and a day in Department of Corrections facilities or enrolling in a therapeutic court, screening at therapeutic court. Like that choice is compelling them to access treatment. And there's these other kind of ancillary experiences that are driving that engagement. And it's not necessarily 100% at will motivated, I'm ready to seek treatment for that individual. There are obviously cases when that does happen, but not, you know, for the majority of people that are in that kind of compulsory treatment situation. And then finally, it was really long-winded. Sorry, this was taking way longer than I thought it would. Involuntary treatment, civil commitment, where there are certain criteria that need to be met, that need to be identified and diagnosed by a trained professional to see, to understand that a person has met that threshold where their civil liberties are going to be taken away from them and they are going to be forced into a treatment setting against their will. And so I think that's what we really come here to talk about today. And I'm so glad that we have other subject matter experts and others working in this area, and it's been great partnering with them. And it's such a critical piece of the full continuum of options that are out there and the different ways that we're trying to support this, like these multiple systems address like this common issue that we see in the communities, which are people are dying and they're overdosing and they're struggling. And so I'm going to pass it off to my colleague, Luke Wagner, who's a supervisor overseeing a lot of our crisis work and a lot of the work around the Involuntary Treatment Act and our involuntary treatment system. And so Luke, hopefully you're there, and I know we got started a little bit early.
Don't worry, Tony. I made it. I'm here.
Awesome. Thanks so much, Luke.
Good morning, everyone. My name is Luke Wagner. As Tony mentioned, I'm the Involuntary Treatment Act and Crisis System Supervisor at DBHR. And as part of my background and professional work, I spent 9 years of my career working in Washington State's involuntary treatment system. Both as a DCR and supervising DCRs and crisis services. And so first off, we just wanted to cover a high-level overview of involuntary treatment, and kind of what that looks like, the considerations involved, and so as we think about that process, every ITA investigation, every Involuntary Treatment Act investigation. Sorry, I want to try and make sure I use the full terms and not just the acronyms. Is balancing two really important things, priorities, primarily, among others. So those two high-level priorities are to protect the health and safety of individuals who are experiencing a behavioral health condition, while also protecting public safety, along with trying to ensure and safeguard individual rights. So obviously, involuntary treatment, being an involuntary process, removes individuals' rights to make their own choices and decisions, and places them involuntarily into a treatment setting. This can also include the loss, or it does include the loss of the right to possess firearms, which is another important loss of rights that can happen with this process. I also wanted to discuss kind of two key different approaches to an ITA, or involuntary treatment investigation. And so you have two options in statute when it comes to either conducting an investigation for a non-emergent detention or an emergent detention. I just wanted to kind of define the differences of those two types of detention. So for non-emergent detention, of course, you're always looking for the presence of a behavioral health disorder. So first and foremost, we need to identify that there's a presence of a behavioral health disorder. And then the criteria for non-emergent detention are that there is a likelihood of serious harm, or that the person is gravely disabled due to their behavioral health disorder. The designated crisis responder gathers information from witnesses and attempts to conduct an interview with the individual. And in a non-emergent detention, a petition is filed then with a judge. A judge reviews that petition and then subsequently makes the decision to authorize the detention for 120 hours or not to authorize that detention or dismiss the petition. This process is not as commonly used in the state of Washington. There are some jurisdictions that regularly use non-emergent detentions, but many jurisdictions across the state don't utilize this process at all or very frequently. The much more common detention type is an emergent detention. With an emergent detention, you shift the standard from likelihood to imminent likelihood of serious harm or imminent danger because of being gravely disabled. And so I've used a couple of terms here that I wanted to also be sure that I define clearly. So first of all is the likelihood of serious harm that I wanted to mention. What we're looking at there is that there's a substantial risk that serious harm will be inflicted by a person upon his or her own person, as evidenced by threats or attempts to commit suicide or inflict physical harm on oneself. It also covers harm upon another. So evidence of behavior which has caused such harm or which places another person or persons in reasonable fear of sustaining harm. And it also, as well as it covers physical harm upon the property of another person. So when we're looking at a likelihood of serious harm, those are the legal criteria that we're using to identify that there is a substantial risk of serious harm. Under harm to self, it's important to note that we're really looking for an intent from that individual to harm themselves. And so we're trying to identify if there appears to be some intent by that person to cause themselves harm. The other term that is used here is gravely disabled. So this means a condition in which a person, as a result of a behavioral health disorder, is is in danger of serious physical harm resulting from a failure to provide for his or her essential human needs of health and safety, or they've manifested a severe deterioration in routine functioning, evidenced by repeated and escalating loss of cognitive or volitional control over his or her actions, and is not receiving such care as essential for his or her health or safety. Could you move to the next slide, please? So the next thing I wanted to cover was the process. So all of these interventions or investigations are initiated by some sort of a contact to either 988, 911, or one of the regional crisis lines. Where I'd like to add something that's not present here on the slide is that within the last couple of years, we've seen an increase in the implementation of mobile crisis teams in some areas where those mobile crisis teams are not staffed by designated crisis responders. And so in some areas where it'll differ from this diagram is that you will always see a mobile crisis team respond first in some regions where they will attempt to explore all less restrictive treatment options with that person, attempt to engage them in voluntary care. And when that fails, or when they're not able to identify any voluntary options that that person is willing to participate in, and they see that there is a risk of harm to themselves or others or grave disability, then they'll refer to a DCR. In other regions, DCRs act in both roles, both as the mobile crisis responder and as a designated crisis responder doing involuntary treatment act investigations. And so in that dual role, they may respond directly. So once the DCR has conducted their evaluation and investigation, which includes speaking to any available witnesses, if they're in an emergency department, consulting with that emergency department physician, looking at any available historical records to identify history and pattern of past events or history of violence. They'll then make a decision whether that person meets criteria for detention or not. If they determine that that person has met criteria for detention, then they're going to start the search for a facility that can accept that individual. And so in the case of detention for a substance use disorder, they'd be looking for a secure withdrawal management and stabilization facility. And we'll talk about those in just a few moments. So they'll provide paperwork and information to a facility that's interested in accepting the person. Once they get a provisional acceptance, they will work on getting transportation from the location where the person is at to that facility. Once transported, that initiates, or once they are they submit that petition, that initiates the 120-hour treatment period or detention period, and that excludes weekends and holidays. So that 120 hours could be 5 days, but if there are weekend days or holidays within there, it could stretch to maybe 7 days, or 7 or 8 days, depending on the situation. So that 120-hour period, before the end of that period, then a probable cause hearing needs to take place with the court. And at that point, the treating facility will submit a petition if they feel that the person needs additional treatment. And so they'll submit a petition to the court requesting an additional 14 days of treatment. And then the court will determine whether the person is held for 14 days of commitment or released at the end of the 120-hour period. Again, so as the person can be discharged at any point during that 14-day treatment period if they are ready for discharge, or they can be held up to that total period of time. And then for the next level would be a 90 or 180 day commitment, or 90 90-day commitment process. Again, you're going to court and petitioning the court for that process. We don't currently have in the state of Washington any facilities specified to provide 90-day treatment for a substance use disorder. There are a few cases where a facility has presented a petition to the court and received a 90-day commitment, but it's not something that happens frequently for individuals being committed for a substance use disorder. All right, next slide. I think maybe Zephyr is coming on next.
Yep, this one is mine. Thank you, Luke. I'm Zephyr, the SWIMS coordinator for the Healthcare Authority. We currently have 3 facilities with a total of 45 active or available beds in Washington State. More facilities are on their way, but each SWIMS has struggled financially. Many of the facilities have struggled with a low census, which means those empty beds are not getting funded. And due to financial struggles, these 3 facilities have already shut down, 2 in 2021 and 1 in 2025. Low census, low reimbursement rates, low referrals, and a high number of court dismissals have all been issues reported by SWIMS. But Valley Cities and ABHS Chehalis, 2 of the first SWIMS facilities to open, are still providing treatment for the Involuntary Treatment Act. And the 2 new facilities coming up, one is in the northernmost part of Washington State, and it'll be owned and run by the Lummi Nation. And then a facility in the Columbia River area in Benton County. And that one is, that facility is owned by the county itself and will be run by a contractor. Both of them, again, will be opening in 2026. So just a quick overview of the development of the SWIMS facilities. And then we can jump to the next slide. Oh, and SWIMS, I see in the question, secure withdrawal, management, and stabilization. That acronym is the name for the facilities that provide involuntary treatment for substance use. Thank you. So the goal is always safety and recovery. SWIMS can be the beginning of recovery for individuals experiencing a behavioral health crisis. The goal is always safety and recovery. Like I said, the services provided in locked facilities are meant to be a last resort. SWIMS are not meant to provide treatment to individuals who would otherwise seek help voluntarily or do not meet the high bar of entry. As soon as the individual is admitted, SWIMS provide a diagnosis, start treatment, and begin developing a discharge plan. Long-term treatment in the least restrictive way possible yields the highest rate of sustained recovery. To meet these goals, individuals also need other services available and accessible. Housing, medical care, mental health care, social assistance jobs can all be part of treatment. Recovery can be hindered without access to basic needs such as these, as we see in individuals who experience higher rates of recidivism because they don't have those supports available. And those are my 2 slides. I'm happy to hand it off to the next person. Tony, I believe you have the next one.
Chat, we'll get to those at the end. Just wanted to acknowledge them and thank everyone for the questions in the chat and then also the additional information from Caleb. So what I wanted to just share real quick was some baseline information as well as post-discharge information, pre-admission, post-discharge for SWIMS facilities. From 2019 through 2024. And so what this looked at was medications for opioid use disorder treatment utilization, both pre-admission and post-discharge for 3 months, both. Out of over 5,000 total admissions, around 3,700 were enrolled in Apple Health. The medications for opioid use disorder does include buprenorphine, methadone, and or naltrexone, or naltrexone. And it's also important to note that this includes individuals who did not have an OUD diagnosis. Just seeing the increase within the 3 months post-discharge from SWIMS with the medication for opioid use disorder treatment utilization across the years, I thought that would be helpful context for the committee and additional information around some of the data that we have for SWIMS admissions. So wanted to include that in today's presentation. Next slide. And then I'm going to pass it off shortly in like a couple of minutes to our guest, Dr. Susan Collins. But first, just wanted to summarize a couple of some research, some findings around civil commitment for substance use disorder that we've identified over the years as we're like talking about this sort of engagement, this sort of intervention for individuals who meet that kind of threshold. So next slide. One of them came out of the Washington State Institute for Public Policy. They published some findings back in June of 2023. They evaluated the outcomes for those detained to SWIMS, comparing them to people never detained, but who had received voluntary withdrawal management treatment in the same time period. We have, again, we'll get these slides out. We'll put them on the website, and we'll also send them out to the committee members. But in the 6 months following treatment, this particular study found that the SWIMS clients were less likely to receive SUD treatment, also less likely to experience homelessness. They were less likely to be treated in the emergency department or be hospitalized, and then less likely to receive any state financial supports. And so interesting findings from WISIP, and I believe that they have also done some subsequent reports, and then we can try to get those links out to the committee members and as part of the notes for today's meeting. Next slide. And then the Drug and Alcohol Dependence Journal did in Science Direct. I missed the year. Apologies for that. It's pretty recent. But the title is Increased Risk of Death Immediately After Discharge from Compulsory Care for Substance Abuse. They looked at 494 persons who died during follow-up, corresponding to an overall mortality rate of 7.1 per 100 persons. Essentially, their findings indicated that the risk of dying after discharge from compulsory care for substance abuse is high. The risk is higher in men than in women. And for young persons, the risk is enhanced during the first 2 weeks, specifically after discharge. And so some helpful information from that Science Direct article to help kind of also additionally scope this conversation. Next slide. And then finally, I think this was towards the end of last year, Drug Policy Alliance put out kind of like their own lit review and findings titled The Drug Treatment Debate, Why Accessible and Voluntary Treatment Wins Out Over Forced. They noted within this document that forced treatment is rejected by scientific and health researchers for being ineffective or harmful, again, citing the increased overdose risk post-discharge. The recommendations within this document are around evidence-based treatment that people can easily access when they need and when they want it. I think that's the key piece to this, like ensuring that there are no barriers for when somebody is at that point in their substance use where they are wanting help, when they are actively identifying their own motivation, their internal motivation for change and accessing services and accessing treatment. And then they also found within this, or recommend within this, that SUD treatment should be voluntary, effective, affordable, accessible, and appealing. That appealing is really, interesting and just, reflecting back on the Health Engagement Hub work that I mentioned really briefly in that second slide, like how do you make those sort of services, those low barrier services, appealing and supportive for somebody who might be really within complicated, extended, long-term substance use. And then they also cited within this one study that found that 1 in 3 people in Massachusetts who are civilly committed for opioid use disorder relapse the same day they're released. So 33% the same day they're released from civil commitment in Massachusetts specifically, unfortunately relapse. And so just wanted to kind of try to tie this back to some evidence, tie it back to some research, tie it back to some data. It's always important. And just so grateful that we have Dr. Susan Collins, who has actually done some of this research and who has looked at this issue specifically within Washington State, join us today. And I think we're doing pretty darn good on time. So I'm going to pass it off to Dr. Susan Collins. Hopefully,
Thank you so much. This has been such a comprehensive talk, so I've really enjoyed hearing about it and hearing about everything y'all are doing here in Washington State. I'm proud to be a resident of Washington State because unlike, and not to be down on too many other states, but a lot of states in the union, Washington State has really taken an effort to really more thoroughly evaluate involuntary civil commitment, which is referred to as involuntary treatment, sort of in the lay speak. And that is really what is necessary right now, and it's not always done. But I want to zoom out a little bit from what Tony said. Tony, that was an excellent kind of quick review of the literature, and I went ahead and put the link to the Christopher et al. 2018 article there. I also put a link below that to a position paper that we worked on in 2022 after we gotten lots of requests around what we thought of involuntary treatment at the Harm Reduction Research and Treatment Center where I work at the University of Washington. And I recently updated that because once again, the idea of, and I'm going to be blunt about this, the idea of forcing people into treatment or locking people up has come up quite a bit in the media. We've heard Eric Adams in New York City saying that, you know, sometimes people need to be treated even if it's, you know, against their own wishes. I'm paraphrasing, but that was basically what he said to justify expanding involuntary civil commitment. And we even unfortunately had a psychiatrist come out and there's an op-ed in the New York Times last week saying, let's see, I'll quote this, and this is kind of what prompted me to go back to the literature and just be sure that we haven't lost our way here. The article in the New York Times is called "Forced Drug Treatment Isn't Horrific, It's a Relief." And this is from a colleague at Stanford. His name is Keith Humphreys, and he's a former Obama staffer, and I will put the link to that guest essay in the chat. That prompted me to go back and double check the literature, be sure we hadn't missed anything, and really made me feel like it's important for us as scientists, as clinicians, which I am both, to really be careful about how we're operationalizing different kinds of treatment across the spectrum, and to be really precise when we're talking about research findings. And this hasn't happened, and that's what led to the confusion, I think, that came up in this guest essay and the ways that we kind of talk about this in the larger media and in social media. To be clear, in the United States, involuntary treatment is referring to involuntary civil commitment. That is different from mandated treatment or court-mandated treatment. So I just wanted to clarify that too, because I think what you'll see if you click on that guest essay is that those two things are mixed up, and also in the systematic review that they link to in that article. So I will kind of walk y'all through what this means, because if you read this, it might have brought up some concerns. Are we doing everything we can for folks in Washington State with really severe substance use disorder and the sequelae? Do we need to expand this further? And so I linked in the chat again to our updated report that we put together in the wake of that. And I'm just going to go through some of the primary research findings. I'm not sure if, Sarah, if you were able to get my slides in far enough in advance to add them to the deck, but I'm happy to also share screen if that's helpful, just to see the literature findings on involuntary treatment and mandated care.
When you should be able to share, if you're
Okay.
not, we also have a link.
Yeah, I'm happy to do it. Okay, let's see if I can figure it out.
And we've got them up and ready to go. Yeah, so we can share.
Oh, you do? Oh, fantastic. Please do.
Okay.
I'm obviously challenged by slide share. Not my forte, clearly. Yeah, that would be great. So what the evidence shows, and I really appreciate, again, Tony kind of zoomed in on some specific studies. When we look across more than 40 years of research, mostly that's been conducted worldwide. So very little of this work has been done in the US, unfortunately. And of course, abroad, involuntary treatment looks different. It's oftentimes being implemented in very different economic landscapes, very different treatment landscapes. And abroad, it can involve civil commitment, but also military or police commitment. But across 40 years of research, involuntary treatment has actually never demonstrated sustained positive outcomes. There have been two more recent systematic reviews conducted in the past decade, one in 2016 and another in 2023. Both of these studies, one screened hundreds of research studies, another thousands, to find studies that have been conducted with some scientific integrity. Some of them are controlled studies, some of them are registry studies, but to give us some idea of what the data look like when involuntary treatment is implemented. And the results have been the same. And in fact, they echo even earlier reviews conducted by Clagg et al. In 2005, and some earlier reviews that were more just, general discussions about what people were finding in the research. There actually is not only 0 studies that have indicated that involuntary treatment has positive effects for patients. Most studies show null findings, and some studies even show negative findings. And the negative findings typically are in the outcomes that people kind of care about the most, like recidivism, and most recently, particularly in the post-synthetics and post-fentanyl landscape, in terms of overdose and overdose mortality, more specifically. Tony alluded to the fact that in Massachusetts, the likelihood of opioid overdose and mortality was elevated. And that has been echoed around the world. So folks who have been looking at that very carefully, for example, in Sweden, there was a registry study involving thousands of people. People leaving compulsory care, which is how they describe civil commitment there, were 2.6 to 3.7 times more likely to die within the first 2 weeks after their release. And mostly that was due to external causes that they classified as overdose. So not only are we seeing negative outcomes in terms of recidivism, in terms of being reincarcerated, but we're also seeing the negative outcomes in the most extreme case, increased likelihood of death. And so now that's been replicated, not just in states here in the United States, but around the world. And I think too, what's really important when we think about this is I think one of the pieces that I get into as a psychiatrist, I work with families, I work with individuals who experience substance use disorder. And I also came up in a family and have my own lived experience of living with and working through the issues that come up when you have someone in your household who is experiencing the negative sequelae of substance use disorder. I have my own experience of addictive behaviors too, and I understand the desperation that a family can feel, that a physician can feel, that a community can feel when someone is, they're experiencing and exhibiting the very real symptoms of substance use disorder, severe substance use disorder. But that knee-jerk response should motivate us to do even more evaluation and more research into what are the best practices to serve those folks who are in some of the most vulnerable experiences of their lives, versus a knee-jerk reaction to, again, as I heard recently, force people into treatment that could really precipitate these negative outcomes that we've talked about. Now, the reason why I wanted to talk about mandated treatment as well, so on the next slide, you'll see that is way more common in the United States. And there are, 34 states in the United States, plus a few territories, already have involuntary treatment for substance use disorder specifically. All 50 states have involuntary treatment for mental health disorders, and that can involve co-occurring substance use disorder. What is far more common in the United States, and I think pretty much anywhere, is the idea of mandated treatment. And that is when a court of some sort, drug court, criminal court, family court, mandates that a person chooses essentially between attending treatment, maybe providing certain kinds of urine toxicology tests, maybe wear an ankle bracelet, but demonstrate that they're engaged in ongoing sobriety, or they face consequences, right? This might be, they will no longer be able to serve on probation, but will be reincarcerated, or they might lose custody of their children for some period of time or permanently. So they have a choice, and that kind of treatment is still consensual. I think it's important just to note that even there, so when we have this formal level of coercion that is less than, but still more intensive than fully voluntary treatment, that we see there are more positive outcomes. So I think what this shows is almost linearly, the more choice a person has when they are struggling with substance use disorder, in terms of how they find recovery, the more positive the outcomes are. But even here, when we see this formal level of coercion compared to voluntary treatment, we see 25 of the studies that have been done primarily in the United States that are mandated treatment studies found null findings. And we still saw iatrogenic effects or negative impacts on people, mostly in the case of recidivism, in 7 of those studies. Now, this wouldn't meet the basic standards in my field of good evidence-based care. So I also want to be really clear about, again, it's a bit ironic that we're providing what I would classify as substandard care to some of the most vulnerable people in our community, the folks who are struggling the most. So I just wanted to bring that up. And so it's not really feasible to provide this kind of treatment as well, because there have been few cost studies, but Washington State is one that has provided really great cost studies, as well as in Sweden. The cost of these highly intensive treatments just far outweigh the potential benefits. The return on investment is very low. So for many different reasons, our center has continued to conclude that there are no positive sustained outcomes for involuntary treatment. They point to iatrogenic effects, and it doesn't really meet the most basic evidence-based standard of care in the United States, and should be used as it is in Washington State appropriately in rare and exceptional circumstances, with strong safeguards, and only as a treatment of last resort.
And I think that thank you so much, Dr. Collins. Really, really appreciate you making time to be here and for sharing that kind of overview of, and I appreciate how you kind of laid that out in terms of involuntary, civilly committed, and then the more court mandated, compulsory type treatment, coerced treatment. And so at this point, I think that concludes like what we've set up in terms of kind of sharing updates and sharing information with the committee. And I think at that, let's open up to conversation. And thank you for our other presenters, Luke, Zephyr, Sarah. for being here, and for Luke and Zephyr for sticking around for the question and answer phase. And so with that, Blake, I'll pass it off to you.
Yeah, you bet. Thanks. Thank you, presenters. Appreciate it. All right, Rep Davis, hope you would pop up. Thank you.
Yeah, thank you so much. So I'll just be really blunt because that's the only way I know how to communicate. I'm feeling actually pretty frustrated and very disappointed with the way that this topic was presented this morning. I find everything from the introductory comments that were read by HCA staff to the literature that was cherry picked to be quite biased in its presentation. And I just think that I will have request a formal follow-up meeting with HCA to ask for a more unbiased presentation and dialogue from others who can present. But I just want to highlight a couple things that were mentioned that were inaccurate and I think problematic. There was a representation made positive studies showing the benefit of civil commitment for substance use disorder. That is a falsehood. There was also, I was particularly disappointed with the cherry pick literature that was presented by the Healthcare Authority. So using the Drug Policy Alliance, which is an advocacy organization, as one of three sources to present literature is deeply problematic. I mean, I think everybody knows the history of that organization and its funding by George Soros, and they have a particular slant. So I think that's problematic. There were repeated comparisons made to the state of Massachusetts, which is also deeply problematic. So the civil commitment law in Massachusetts is called Section 35, and it is a deeply, deeply, deeply flawed system in which they are sending people to carceral facilities, correctional facilities staffed by corrections officers. There's absolutely no resemblance to the way that substance use disorder ITA is, the way that treatment works in the state of Washington. And so I think it's really important when we consider any literature that we really look at what we're doing in Washington, which is a very new system and it's very, very different. It's as trauma informed as civil commitment can be. Medications are offered. It's incredibly thoughtful and effective. There are also flaws with the WISIP study. So the deepest problem with the WISIP study is that they use the comparison population as individuals who went to voluntary treatment. That is not a fair comparison population for sort of Ricky's Law patients or substance use ITA patients. Substance use ITA patients are people who are, again, it's always used as a last resort, who have been unwilling or unable due to the severity of their substance use disorder to seek voluntary care. So the notion that you're going to compare them to people who seek voluntary care, it's apples and oranges. The appropriate comparison population would be people with equally severe equally severe substance use disorder who cycled through emergency departments and the carceral system due to the severity and acuity of their substance use disorder, who did not receive any treatment intervention. That would be the appropriate comparison population. And I'll also just say, like, I really reject the characterization that the substance use disorder civil commitment provided in Washington state is substandard care. I think it would be really prudent for us to actually hear from some of the folks that actually do that work. I think it would be also important to hear from other academics in this space. This is certainly a hotly debated issue, but I just want to go on the record that the presentation from soup to nuts, top to bottom, that was presented this morning was deeply biased, and I would formally request that we have a second conversation that is more balanced. Thank you.
Thank you, Rep Davis. Appreciate your comments, your dedication to the subject.
Blake? Hey, Blake, just real quick, I just want to respond to that. Yeah, Representative Davis, really appreciate your comments. I made notes and looking forward to the follow-up meeting to discuss how to bring in additional information to the presentations. Definitely wasn't any intent to cherry pick certain research. Those were just the articles that I've stumbled upon. And oh, am I muted? Oh, okay. And so yeah, I just wanted to acknowledge that, and also just regarding your first comment, you indicated in the chat you didn't find it to be accurate to suggest that SURSAC ever considered SUD ITA. It was not part of the legislative directive. I think within the opening statements, what we were trying to summarize was that SURSAC has looked at the full continuum of services as it made recommendations, and specifically the subcommittees. Those subcommittees that met were looking at gaps in the system, and in order to do that, you have to look at the totality of the system. And so that was what we were trying to convey, not that it was part of the legislative direction. So just wanted to address that chat comment. And again, thank you so much for your feedback on the information shared today. Blake.
All right, Dr. Collins, did you
Yeah,
want to
I did
comment?
want.
Since you're a presenter, I'll go with you first.
Yeah, no, I appreciate that. So I appreciate how much work, and I do want to reiterate to you how much work Washington State has done compared to other spaces, other states, other countries in terms of trying to evaluate how this has been going. So I'm certainly not putting that in the same container as Massachusetts. This is the literature that's available, and I think what you're underscoring, Representative Davis, that is so important is that there needs to be more ongoing research. And one thing that is notable that I think is also really important is the WISIP report does not have a report about overdose mortality included in it, the 2023 report. So it would be good to, I know at the time it was during COVID, and they were unable to get the health records in time to include those data in the report. But because that is such a massive negative sequelae that we're seeing from involuntary civil commitment in other states and in other countries, it would be really important to replicate that finding here in Washington State. That being said, as I mentioned at the beginning, Washington State is doing everything right in terms of how this law is used sparingly and appropriately, and also is measuring the outcomes, which a lot of other states are not doing. So don't mean to belittle Washington State in any way for the good work that's being done. And we need to continue to do the evaluation. So if anything, I think what I'm trying to say is there's an impetus to have more evaluation so that we're not relying on the last 40 years of work that's been done in other countries or in certain cherry picked states. But that is the state of the science. There isn't another science out there to draw from. We need to fill in those gaps for sure. It's a call to action, I guess.
Thank you. Addie.
Thanks so much. I actually had a clarifying question on a slide that Tony shared about the MOUD at the time of admission and then after. It looked like it was some 20% at the time of admission and then slightly higher after. Was that 20% of all the people who were eligible for MOUD or had an opioid use disorder, or 20% of people admitted had opioid use disorder?
Yeah, that was actually the entire population, Addie. Sorry, I didn't clarify that. So
Okay.
it was of everyone admitted into SWIMS, regardless of diagnosis, how much received some form of MOUD treatment 3 months prior, and then how much received 3 months after.
Okay, thank you so much. I appreciate that clarification. And I did just want to address Rep. Burnett's comment in the chat around responding to overdose with sending people to inpatient treatment. That's not an evidence-based response to opioid use disorder or to opioid overdose. The evidence-based response would be easy on-demand access to MOUD like buprenorphine or methadone. That has the highest standard of evidence for opioid use disorder. And as was presented in this presentation, when people go to inpatient facilities and lose their tolerance, they're at very high risk of subsequent overdose and death. So thanks so much.
Blake,
Thank you,
before
Ed.
we move on, if I can clarify as well, I think it's important to tease apart the population of people who use drugs and people with a substance use disorder. And medical necessity is really important piece to look at in all of this. And so somebody can overdose using a drug for the first time, using an opioid for the first time, particularly with the presence of fentanyl. And so if that person has just used a drug for the first time, they don't have a diagnosed substance use disorder, they wouldn't meet medical necessity to treatment. So not only would treatment, maybe not be an appropriate response for that individual, but certainly treatment at the far end of the spectrum where someone's civil liberties are taken away would not be an appropriate intervention for someone in that situation.
Thank you. Thank you, Addie. Malika.
So I just want to say thank you to the presenters for sharing the information that is actually available and that has been studied as rigorously as it can be under the circumstances. I also think that as we're challenging ourselves to be better in Washington State, we need to make sure that we're not being defensive about particular legislation that maybe was well intended. I think we need to really look at impact versus intent. And so, like the intent of a lot of our ITA legislation is good. I think used within the proper context, it's not bad. I think also that there's more room for us to grow in the state. And also as a person who lives outside of Seattle-King County, people getting access to the supports that they need and being able to actually even trigger that system when it is appropriate is nearly impossible. And so, instead of being, I think that part of the greatest form of wanting to improve things within our state means that we can take a critical eye to what the law is and what is actually happening, because there's a huge disconnect around most of the state and probably even within Seattle-King County, because we do not have enough resources. We do not have enough, we don't have enough DCRs for the folks that it is even appropriate for them to go into an ITA situation. People are waiting hours if they even get a response. So, and I'm saying this is just as a citizen that lives, that has family members that experience SUD and other behavioral health issues. So, and that have potentially needed to access. And I also say this as a professional that works in the community and as a volunteer. And so I think that, it is concerning to me that it feels like we're kind of throwing the baby out with the bathwater here rather than being able to take a critical eye to what the law says, what's actually happening, and how we can improve it. And one of the strengths of this group that I have noticed throughout the years is that we're able to make concrete recommendations that hopefully get paid attention to somewhere and can help make things better. And I also don't think that we can do a sufficient job of looking at everything within an hour and a half meet or 2 hour meeting. So I'm hoping that we're going to have longer conversations and maybe some work committees. I know we've talked about it, so this isn't a critique of anybody. I'm just saying it's something that we need to think about. And yeah, I'm saddened to hear the responses to the information that has been presented to us today, because unfortunately it's pretty largely accurate from my experience. But yeah.
All right. Thank you, Malika. Chad.
Actually, that's, I guess to kind of add on to what Malika said, but let me just first say, in terms of what Rep. Davis said, I agree. I thought that the comparison populations were not entirely accurate and didn't present a good picture. But what's happening? What's actually happening? I used to do these civil commitment hearings probably about 10 years ago, so I don't know that this is still the case. But at least 10 years ago in Kitsap County, I would get 1, maybe 2 beds a month for the entire county. And we would be able to civilly commit 1 person. Usually that 1 person would agree to the civil commitment. So this was an agreed involuntary commitment, if that makes sense. And we would send them off and they would go and they would use that 1 bed, and usually they would leave the facility shortly thereafter, that it wasn't actually a secure facility. and it wasn't something that people would stay for. And then I was had the dilemma of, okay, what do I do now? Do I issue a warrant to have this person arrested? And if I do, I just drag them back into the treatment that they didn't want to be at in the first place. So my biggest problem with the way that we had operated this in the past, and I don't know if this is still the case today, is just we didn't have enough beds. It didn't make it practical. It didn't make it a dent in what we were doing. So.
Thank you. Thank you for your comments. Rep Burnett.
All right, thank you. My original comments on the chat line was specifically to being involved in my own community with my 25 years of law enforcement experience, going back touring DOC reentry facilities that are current and accurate today. And as the state continues to close Spokane and Yakima centers down, and then transition homes. But when you talk to the professionals on the ground in our local communities, Malika, you kind of alluded to this, and Chad, you just hit on it. There's no bed space, and everybody is saying that we have to get people into treatment. We have to get people through rehab. It doesn't matter if they're coming out of a DOC sentence for 20 years and haven't been through rehab. They don't get to go to the re-entry center and go find a job and start working until they've completed rehab. They've got to check those boxes because they're still under addiction and prone to that, regardless of what you call it. But in the same thing. So as I talk to DOC, as I talk to local corrections, as I talk to the local Center for Drug and Alcohol rehabilitation, there's not enough bed space. And then we know it comes down to funding, but I look at this as it's just like the early learning committee that I'm on. You either invest the money up front or you're going to pay multiplications down the road. It's going to cost a lot more to deal with the serious drug addiction and implication, not just to the people that are involved in society and people of homelessness, to people of committing personal property crimes, but what that impact does to society for the crime rates, retail business, but to the personal family and what that's like. And I think that's the passion that Rep Davis brings to the table, is that like, yeah, well, it may be doing this little bit of difference and we might have some good results in this very small population, but look around you. 5-10 years ago, when I was in law enforcement and here in my own community, we didn't have jack for the stuff that was going on compared to what it is now. Wenatchee is 38,000 to 40,000 people, and it is a mess. They can't keep up with it. And then we're keeping people from overdose. And I brought this up at our last meeting, was that we're slowing down the death rate of people of dangerous drug overdose if it's being reported accurately. And I have some questions and concerns on that. But literally the drug addiction and the overdose themselves are rampant, and it's not slowing down. It's at a trajectory that's completely steep like this. And that's where we have to look at, is like, do we want to make a difference? Then we have to start doing some things different. So I'll hold it that our passions are always going to be strong because this group wants to make a difference. But I think we're going to have to really take a look at local tactics on what we're going to do, and we're going to need bed space, and we're going to have to start ITAing people. And I'm not talking about first offense. We're talking about people that are exposing themselves to dangerous drugs and exposing themselves to overdose and potential death. And that in itself, it should be somehow be able to use a court order to be able to make a difference. Otherwise, those people are eventually going to die. So thank you.
Thank you, Rep Burnett. Caleb.
Good morning. I'm really happy for this conversation. Thank you. I do hope that we can not just get into our camps and throw things at each other. I think it's important to think about a couple different things, and I really appreciate Rep Burnett raising a couple of these issues. So I think I've been honored to work in this area for several decades and talk with folks all around the states, professionals, community members, all sorts of folks, all sorts of different types of expertise, which I think is really important to think about that framing for what people bring to the conversation. And I think in that instance, we think about rehab, and we think about people need rehab, and that's a common expression about what we think about around services for folks with substance use disorder. And it can mean different things to different people, but I think, in my experience, the default is often inpatient treatment. And I really encourage people to hear what Dr. Collins is saying and others are saying, is that despite the long, long history of inpatient treatment, does not have a strong evidence base in and of itself, and certainly when it is mandated. We can quibble about comparison groups, one of my favorite topics. In the WISIP report, that was not the only evidence that Dr. Collins cited, so I think that's important to keep in mind. And then I think maybe for future conversations, another way to frame this as well is, what is the evidence, which you just heard? What is the ethics, which we've not particularly discussed, but is pretty darn important? And then what is the capacity and resources? So I think those three sort of framing devices can really help us maybe have a conversation about where we might end up from a policy and practice perspective. So thanks everybody for contributing to the conversation.
Thank you, Kellen. Appreciate that. Yes, a lot of great comments. I'll throw it back to the room there, see if there's any to take us out. This subject anyway.
Yeah, no, really appreciate everyone's input and questions and additional comments around this topic. Sounds like we'll probably have more conversations in this area, and hopefully bringing additional research, additional evidence, hopefully some more data back to this group. And also just wanted to just quickly remind everyone, in terms of the SURSAC's role and what the legislation authorizes and the RCW, the committee was tasked with developing a plan, a substance use recovery services plan, and then that plan was crafted in the scope of about a year, and it was submitted to the legislature, and then all authorizing elements of the RCW is tied back to that plan. And so we can continue to have conversations around how involuntary treatment and secure withdrawal management stabilization fits within the continuum of care for individuals who use drugs. But in terms, I heard like recommendations, I heard some other, I just want to help scope like what the committee is currently able to look at, which is tied to that plan. And so a lot of our conversations, a lot of the updates, a lot of the information we've been bringing has been tied to that plan for the past year and a half. This is really the first time that we kind of branched out apart from that because of the questions from Representative Manjarez at the end of last month's meeting, and then also like the really quick engaged conversation and feedback that kind of led to. And so didn't want to like stifle that sort of collaboration and conversation and dialogue. And I think it's extended into today's meeting as well. And I think it's important, but just wanted to try to, make sure that we all still understood that as far as the committee and what's authorized in RCW, like we had the chance to develop a plan. And so really, the focus is tied to that, and our progress reports and implementation reports on an annual basis are tied to those initial 14 recommendations that were in that plan that we submitted back in January of 2023, a couple of years ago, 2.5 years ago, almost 3 years ago. I can't believe it's already September. Blake, there's still some hands, and so I want to allow additional time for conversation and dialogue around this. And so I will pass it back to you to facilitate that. And thanks so much.
Thank you, Tony. Malika, did you have another comment?
Hey, Malika, because my computer gets real quick.
All right. We'll go to Dr. Collins.
I do have another.
Oh, you do? Okay, sorry, you froze it to me a little bit.
Yeah, sorry, my internet is a little sketchy right now.
Go for it.
So one thing that's really coming up for me, like as we have this conversation and maybe all of our ruffled feathers begin to settle down a little bit, is that potentially, when we're talking about what research we have, like speaking about what research we have, and then noticing what's missing, like these are all like byproducts of having a prohibition-based system, is that we can't research things in the ways that we need to because people are scared to engage in the process. But that's another day, another topic. But I do think that something really critical did come out of this exchange today, was that this apples and oranges conversation. And so like, how do we figure out ways to be able to engage with the people to make it apples for apples? And I feel like that is a recommendation that could potentially in the future come out of SURSAC, is that we begin to analyze thoughtfully what is missing, what would create the research outcomes and information that we would love to have. And since it doesn't seem to be readily available, what work do we need to do as a committee to be able to figure out how and what? We have a lot of people on this committee that could help us do that. And then also whether or not it's actually going to be productive and appropriate, because we do have limited resources. And to the point earlier, somebody said, let's continue to do what works. Yes, let's continue to do what works. And also, we also do policy aren't working, and really take a good inventory with the folks that are working in those communities about how a particular policy is or is not being implemented in their community and why folks think that reason is.
All right. Thank you. Dr. Collins.
Yeah, so I was asked to just summarize the research literature. I didn't realize that I didn't realize exactly what policy discussions I'd be walking into. The research literature, the larger literature over the past 40 years, is pretty clear. But what I do think is important too, in considering the specific context that we're in Washington State, is I want to underscore once again that Washington State is one of the few states that has actually taken the time to evaluate involuntary treatment, which is commendable. And I did want to share some of those findings, because I had kind of thought this group was familiar with those, but they are more promising. And I think this underscores Malika's point of the work to be done. So it is the case that there were fewer ED visits among clients who were involuntarily treated, and fewer hospitalizations than in the voluntary detox group. Those folks were less likely to receive financial support, though, than the voluntary detox group. There were no significant differences between the two groups on mental health treatment, arrest, or employment outcomes. But it is important to say that the return on investment was low, as was shown in the Swedish studies as well. So it's mixed findings, right? It's not all bad in Washington State. So I think this really underscores Representative Davis's point, which is this is a different system. It's important to be sensitive to local conditions. And that's something the larger research literature and our big scale meta-analyses and systematic reviews cannot always take into account. I did want to underscore too that there were other, they weren't necessarily involving inferential statistics, like really comparing the groups, but there were some data in the appendices of the WISP 2023 report that did indicate, on the balance and just eyeballing it, more positive outcomes for the involuntary treatment group than for a group that didn't get a bed, right? So there was that data that was presented. I think it would be helpful to have different kinds of comparison groups and show the data in different kinds of ways, so we can look at things more holistically. I know, as Caleb mentioned, we kind of fetishize that in the research world because we decide what is the most appropriate control group. In this case, to get everyone's questions answered, I think WISP could go back and really do more analyses there, just to answer Representative Davis's questions. Those data are there, but they just weren't part of the main report. The last piece, and I really want to underscore two more pieces. The last piece about the WISP report is that we don't have those overdose and mortality data in that report, and I couldn't find them. Now, maybe they exist, but I think those are really, really important, because that is one of the most severe outcomes that has been talked about in the literature on involuntary treatment, is the concerns, especially in the synthetics era, of the very heightened risk of overdose death. So checking into that, just following up on that. And then the last piece, and we referred to this in the report that I linked to on our site, does go over qualitative. There are actually reviews of qualitative studies at this point. There are so many qualitative studies on people who have been and who have received involuntary treatment, primarily for mental health problems. And those data show quite clearly people's experiences, their lived experiences in those settings. And so reading those, having this group read those and really understand what are the perspectives of folks with lived experience of the facilities is going to be key in moving forward as well. So just wanted to provide those. As a researcher myself, those are the things I would care about in terms of next steps. And ensuring that any research that's done, that you maybe, have a community advisory board that is also made up of people with lived experience. This is, again, a rare treatment to experience, as it should be, right? We want people to be in the least restrained settings receiving, treatment as they possibly can be. So not many people experience involuntary treatment by design, but having folks with lived experience who can also join that conversation when it comes to presenting the research findings or the evaluation findings and contextualizing them and interpreting them is really, really key.
All right. Thank you very much. Appreciate everybody's input on this subject. Thank you. Tony, I'm going to throw it back to you for the next subject.
Yeah, no, I saw Julian Saucy.
Yeah. Oh, yeah.
I just want to make sure. Julian, did you have a question or comment?
I did, yeah. First, I wanted to point out that the Dr. Collins report kind of surprised me a little bit, just that in a good way, that the that people that were in like almost like coercive but not forced treatment had better outcomes, which was good because I didn't know if that's going to actually happen. Also, just a reminder that when we take up, there's always not enough beds, but when we force people that are not in a space to want to help, we're wasting beds. We just need to be careful about when we're doing that. Like when we just have rules that automatically put people in a situation to take up a bed when they're not ready for a treatment, that doesn't help. So, yeah, and I just had a friend who just went through a situation where he ended up in at a county jail, and although he wasn't like one withdrawing, he could hear people like just screaming and just like in pain, and no one even cared about them. No one's paying attention, but everyone deals with that, and then the people in the jail get angry at the people that are screaming, and it's just like a cycle that's not a place for people going through care. And getting to why, getting to the why. Sorry, but like I think if there's a way to get data that you can figure out like why they were using drugs, because some people get some sort of relief for some reason. It's helping them, or it's making them block out situations, or it's whatever it is. And some of it could be by the severity of their whys. Who knows? Thank you.
Thank you, Julian. Appreciate that. Rep Davis, please.
Yeah, thanks. Just a quick comment in regards to what Julian just said. It is absolutely correct that people are not going to be able to stop using until they're willing. I think what's really important and why the data is so relevant and why it's really important to talk to the actual people who are doing substance use disorder civil commitment in this state. So the providers and the ITA prosecutors and public defenders who do that work. The overwhelming majority, upwards of 80 or 90% of individuals who are civilly committed, so they are unwilling at the moment of crisis to seek care, the overwhelming majority of those individuals are converting to voluntary care willingly. So what we know about this disease is that when people have such severe addiction, they are often losing that gift of choice. They're losing their volition. And we see almost without exception in patients detained under Ricky's Law, usually around between day 7 and 10, there's a conversion and people have that gift of choice that returns. And overwhelmingly, over and over and over and over again, people choose continued care. They choose to stay in the facility voluntarily, and then they choose to transfer directly off into inpatient residential, to continue on medications for opioid use disorder, to continue with IOP. So we see this over and over and over again with that patient population, which is why I think it would be equally important to get some of that qualitative evidence that it's Washington state specific. Again, our system is very different than any other SUD-ITA system in the country.
Thank you. Thank you, Rep. Davis. All right, any more comments?
Yeah, Blake, I just noticed Nikki put something in the chat. Nikki, I wasn't sure if you wanted to share that with the group.
Yeah, I think for me, I don't hear a lot of conversation about, it gets tricky, right, with mandated treatment and recurrence. But I think that is something that really should be considered because, as I said, it's not something, it's unique in the SUD realm or in the medical world that if someone experiences recurrence from a chronic condition, that they're requested to leave and essentially not given treatment anymore. And so I don't hear that discussed a lot. And I think that that is important just in terms of continuum of care. And then I see folks at all levels of treatment, willingness to engage in treatment, and the social determinants of health are so important. And engagement and treatment is one thing, but we have to have people set up for success once they leave treatment. And I think we have a lot of work to do in Washington in terms of that and supporting people and considering their whole health. I think, you know, as discussed, Washington may be on a better road than other states, but I still see that as just such a huge need and a huge reason why people don't engage in treatment and then feel unsupported and go back to their use. Thank you.
Thank you. And Rep. Manjares, please.
Thank you. So I really feel very encouraged by some of the conversation that we're having. Rep. Davis, I don't think we have used the you know, the DCRs. I don't think that are recommending the involuntary treatment in front of a judge. I talked the DCRs, I mean, designated crisis responders. Right now, our EMTs are our police officers. I don't think they are not DCRs. They're not designated crisis responders, even though they are the first ones on the scene of a crisis. And we don't have DCRs all across the state that are 24 hours a day that can come and make those analysis. I was happy to hear Rep. Davis say that we need to give them, we need to have some kind of a detox period to give them the ability to choose voluntary treatment. Heavy substance users, especially in the synthetics like we're talking about here, they're not in a clear state of mind. We have to give them, and the only way to do that is to give them into a detox period. You know, the gentleman that talked about the screaming in the jails, we have to have the beds for those people to go to those facilities so someone is helping them from a medical perspective, so that they're not sitting in our jails like that. The focus for this state has to be more beds for the long-term treatment. The plan, I mean, it's not working. It's not working. A lot of people said here that there's some things that are working and you know what works, but the total plan is not working. And we have to look at changing the plan. Thanks.
Thank you. Malika, please.
So over the years, y'all have been like, we need to be solutions focused. We need to be thinking about, so like if we go with, which I agree with you, Representative Manjares, that, you know, we've got to try something different. Like we need to build upon what we have, and we need to figure out where the gaps are so that we can change that. And there's a lot of research that has been occurring over the years that it would seem, I mean, I guess it is good to ask the people that are doing a thing whether or not they're doing the thing, but you're only capturing the people that actually make it into the system. So when we're finding out what happens with ITA situations that people actually make it into that system, that's good information to have. But just as a person that works with law enforcement across the state and that is involved in a lot of different things across the state, I repeatedly, and we've talked about it here, is that the implementation of this law is not actually working in the ways that I think we want it to, or that it was maybe intended to, as I mentioned earlier. And what comes to mind is the CLEARS work that's been happening out of the University of Washington about reducing stigma between law enforcement and people experiencing SUD, has happened in diverse communities across the state. So eastern, western side of the mountains, small, large, in between. And it just seems to me that like we have a starting point there where we can start asking some of these questions, because it is good to hear what happens for the people that actually make it to the system, but we need to be talking about people that are trying to Rep. Menhar's point earlier, that like what's happening in the community, that a lot of folks are never making it to that space that is appropriate for them, if it's appropriate for them. And what is occurring that is making it so the intent of this legislation is not being realized in the ways that would be felt by the communities that are seeking support? And what are the things that are missing in between that last option that could help mitigate the things that people are experiencing in their communities? And it just would seem to me that that would be a place to focus, and that we need to, I'm sure a lot of things are in a lot of those conversations. So, I mean, from a solutions-based perspective, it would seem to me that it would be important for us to work with what we've already started with and build upon that. And I hope that made sense for folks.
Thank you, Malika. Luke?
Yeah, I just wanted to share a little bit about designated crisis responders and their availability across the state. So our current healthcare authority contract with each of the behavioral health administrative service organizations that cover the 10 regions and ensure that there's crisis services in those regions are required by current contract to have designated crisis responders available 24 hours a day, 7 days a week, 365 days a year. So I do welcome any members of this committee, if you have concerns in your area where you feel that that's not being met, we'd be happy to gather that information, receive that information, and look into that further, because it is important that per the contract, per statute, for the benefit of our communities, that we have DCRs available 24/7 in every county of the state. So I just wanted to add that information.
All right, thank you, Luke. And we'll turn it back over to Tony. Tony, you want to take us out?
Yeah, so a couple of things. One, Brianna, thank you so much for being prepared and ready to present on RNP quarterly report data today, and also your flexibility in being available for the next month to share those data. Obviously, we ran out of time. I think it was definitely a good thing. The conversation was so incredible, and it was just great to get so many different perspectives and hear from committee members that we haven't heard from in a while. And so I think that it was time well spent, but also just wanted to acknowledge and apologize for basically eating into the other agenda items into the meeting. Second, Dr. Susan Collins, Luke Wagner, and Zephyr Forrest, just thanks again for coming to this meeting today to share information, to share your experience, to share research around this topic. Incredibly appreciate you taking 2 hours or an hour and a half out of your Monday to come to the committee and help inform and help fuel this conversation and the dialogue around involuntary treatment as it relates to people who use drugs. and just really, really just want to thank you for being here. Finally, I feel like there was a number of things in the chat that we weren't able to explicitly call out. And so just kind of like an encouragement or a recommendation for future meetings, like, you know, TBW is live streaming this. There's so much good information and thoughts that are being shared in the chat that aren't captured. And so just always feel free to raise your hand and engage in the conversation. You know, obviously the committee members as well as public, like we try to, you know, build in time to allow for that. One thing that Caleb or somebody mentioned was like talking about next steps, like having another presentation about beds, about rehabilitation, about inpatient treatment. I just want to remind everyone that we no longer have a SURSAC administrator. So as part of our state's budget cuts and budget reductions, Washington State Healthcare Authority has had to identify a number of areas where there was an ability to identify cost savings, and we've even gone through a layoff process at the Healthcare Authority recently. That position is no longer available. So we're doing this within existing resources for staff that have other responsibilities and other work. And so I just wanted to flag that, just as we talk about scoping this and talk about future presentations and how to utilize future committee time and this space, is that we're doing all of this work within continuingly reduced resources at the Healthcare Authority and across the state due to the budget situation. So just wanted to make sure that the committee was aware of that. Obviously, within the past month, we did what we could to bring together a number of individuals to bring information to this committee today to inform this conversation, but just wanted to flag, you know, that there might be barriers going forward. And we might need a little more time. I know a month seems like a lot of time, but in the grand scope and the grand scheme of everything that's happening, it is a limited amount of time to really pull together a comprehensive, fully fledged summary of all the work that is happening in this amazing state and in all these different areas. Finally, I wanted to say as part of closing comments, for the October agenda, we'll have a presentation from the Oregon Criminal Justice Commission on the Behavioral Health Deflection Grant Program, as part of kind of what we've heard as feedback about how to use this time to get updates about what's happening in Oregon around simple possession and criminal possession of controlled substances, as well as part 3 of our lead education series with the Lead Support Bureau. And then finally, the Mentee results. We did send out an email to all the committee members, over 20 of you, asking for feedback as to how to utilize time in 2026 for the next year in terms of receiving updates around implementation of that substance use recovery services plan. We only received, we received limited responses. So I'm going to send that out again. So just wanted to flag that. And I think this conversation will hopefully inform some of the feedback and responses that we get to that Mentee opportunity to just gather feedback outside of the committee and gather feedback and try to collect it to help inform how we utilize this time and space going forward. With that, we are at time. I just, again, thank you all. Thanks for being here. Thanks for all the work and also the interest and passion around this topic and helping to improve lives and helping to save lives. And just feel like this was a really good use of our time today, and looking forward to future conversations. And we will send out the minutes and presentation resources within the next week. And as always, feel free to reach out to me. And Michelle Martinez should be back, who's helping to support this work going forward. Later on this week, and Michelle's always available as well. We have our generic inbox for follow-up comments as well. So with that, appreciate everyone's time, and we're going to go ahead and conclude today's meeting. And thanks again, everyone. I hope the rest of your day and the rest of your week goes well, and take care out there.